I'm Shernan Holton, Associate Professor of Medicine at the University of Minnesota, here to give a very brief introduction to the field of blood and marrow transplantation and immune effector cell therapy. This is the outline of our talk today. First, we'll review briefly the history of blood and marrow transplantation. We'll discuss the different stem cell sources that we can use for transplantation. I'll share an update in prevention of the most common complication that presents a barrier to transplantation, and that is graft versus host disease, or GVHD. We'll discuss the unmet needs that are remaining in our field of blood and marrow transplantation and end with a brief summary of immune effector cell therapies and brief discussion of where this may be going in the future. Some of you may know, after watching the blockbuster Oppenheimer over the summer, that our field was originally developed to help treat people exposed to nuclear radiation. With exposure to radiation between 0.7 and 10 gray, a phenomenon known as bone marrow syndrome can develop. This essentially causes destruction of the bone marrow and all of the hematopoietic cells within it, leading to marrow aplasia. Without the ability to create new blood cells or develop new immune cells, patients end up succumbing to infection or hemorrhage. So the field was born out of the need to address radiation syndrome, specifically the bone marrow compartment. And even to this day, there is a radiation injury treatment network that exists around the world, of which the University of Minnesota participates, that is ready to mobilize in case there is a need to perform a number of blood and marrow transplant procedures at scale in case there is a nuclear incident. So these were the beginnings of our field, although, as you know, it really evolved to deal more with leukemia, myelodysplasia, and cancers of the bone marrow. But this is how we got our start. So as we know, the first atomic bombs were dropped in the 1940s. In the time surrounding that period, there's a lot of work to be done to figure out how to protect the body or restore damaged organs after radiation exposure. So it wasn't until the early 1950s that it was discovered that there was a hematopoietic stem cell that, if protected and shielded from radiation, could repopulate the bone marrow and restore blood and blood formation and immune function. In the early days of our field, the first successful transplants were done with identical twins because at that time it wasn't known how to perform matching so that rejection wouldn't occur. In the late 1950s, there was the first description of HLA, or human leukocyte antigens, that were further studied over the coming years to make it possible to determine precise tissue typing. But up until that time, matching was essentially done in a dish where there would be a lymphocyte reaction that was monitored, or even through skin grafting from a potential donor to a potential recipient to see if they were indeed a complete match. In the late 1950s, there were some procedures performed to help workers who were exposed to an accidentally high amount of radiation, and some early success with that. But with some of those early successes came the first descriptions of this immune reaction called graft versus host disease. As the field evolved and we were able to determine more precisely the tissue typing, or HLA typing, of donor-recipient pairs, in 1968, the first successful HLA-matched sibling transplant was performed at the University of Minnesota for immunodeficiency by Dr. Good. And it was several years later, then in the mid-1970s, when the first successful unrelated donor transplant was performed at Memorial Sloan Kettering. So quite a history. Over this time, transplantation was viewed as highly dangerous, highly experimental, potentially even unethical, but over the decades has now really become the standard of care for treatment of a variety of malignancies and disorders of the blood and bone marrow. Now we can use several stem cell sources to perform transplantation. Historically, we got our stem cells from the bone marrow, but we know that we can actually use a number of sources now, including mobilization of stem cells into the peripheral blood, as well as cord blood. That is a rich source of hematopoietic stem cells. We can potentially even modify stem cells in the lab, expand them, grow them, correct their genes, and do a variety of manipulations to achieve the goal. It is no longer true to say that bone marrow transplantation is really an aggressive therapy that is highly experimental. Now it's really standard of care, and so many possibilities exist using the different stem cell sources to help patients overcome their life-threatening conditions. So historically, we learned that syngeneic or identical twin bone marrow transplantation was the first stem cell source used. There are some times when a person can use their own stem cells. That's known as an autologous transplant. Now, the way an autologous transplant works is that we collect stem cells from the person and basically cryopreserve them so that the stem cells are safe and protected and can exist for a long time. And then we give the patient high doses of chemotherapy or radiation that essentially wipes out the bone marrow function and resets the immune system so that now we can put in these new stem cells and allow regrowth of the bone marrow, regrowth of the blood system, regrowth of the immune system. And it really starts anew so that potentially any immune problem that was there before could be resolved with the growth of the new immune system. And any tumor cells that were remaining when we're doing autologous transplants for cancer could be treated by the high doses of chemotherapy conditioning. So in a sense, this is sort of a self-stem cell rescue, but in effect, it really resets the immune system. In contrast, allogeneic transplantation is where we use cells from a healthy donor to help treat a variety of conditions or provide a graft versus tumor effect. An allogeneic transplant is not always myeloablative. It is possible to use lower doses of chemotherapy and radiation, really leveraging the new donor's immune system to help treat the underlying condition. This provides a new immune system to fight cancer or could even replace cells that are defective through replacement of correction of enzymes or other functions of the bone marrow that may have been disturbed by a variety of mutations or conditions at birth or acquired later. So a wide application for allogeneic transplant as well, beyond just treating cancer. This graph shows the number of transplant procedures performed in the United States that were recorded by the Center for International Blood and Marrow Transplant Research by transplant type. And in blue, you see steady growth of allogeneic transplantation, really starting to take off in the 1990s and continuing to increase through 2020, and certainly increasing beyond that. It is currently estimated that about 10,000 people undergo allogeneic transplant a year in the United States. In green, you see the number of autologous or self-transplant procedures, and there was a blip with a rapid increase and then decline in the mid to late 1990s. That blip represents breast cancer. There was a time where autologous transplant was performed for advanced breast cancer. That has subsequently fallen out of favor after research has shown that that was not an effective therapy. But now that we're past that blip, autologous transplant had continued to grow up until the year 2000, now appears to be declining potentially a bit, and that is in part due to immune effector cell therapy that we'll be talking about later. This graph shows the number of transplants performed in the United States by donor type. In blue, historically matched related donors or matched siblings were the most common donor type. But in orange, you can see that matched unrelated donors from the donor registry have taken over as the most common graft source. In green, we have haploidentical transplants. A haploidentical transplant is a transplant from a half-matched relative. Typically, it could be unrelated, but most commonly this is a half-matched relative, meaning this is either from a parent or a child. And that has really increased since 2015 and beyond due to the improving safety of that procedure. And over time, in those who do not have a matched sibling or do not have a haploidentical graft available to them, the development of alternative donors, including mismatched unrelated donors and cord blood, has made it possible. So now that really, essentially everyone who needs a transplant should have an available donor. This graph shows the number of transplants by indication and transplant type in the United States in 2020. Far and away, the most common type of transplant in the US is an autologous transplant for multiple myeloma or plasma cell disorders. You see a very small number of those patients undergoing allogeneic transplantation, and the reason is it's not all that effective in that disease and it is much more risky. So that is the most common indication for a transplant in the US. In blue, you see allogeneic transplantation, and the most common reason for that in the US is AML, followed by MDS, ALL, and a variety of other non-malignant diseases. And so you see, we also have some autologous transplants for lymphoma, non-Hodgkin lymphoma, Hodgkin lymphoma, and other malignancies, including germ cell tumors and others. And this here just shows you the landscape of procedures performed in our field in 2020, and I do think that this will continue to evolve over time. Speaking about allogeneic transplant, the major barrier to success of using a new donor to restore the immune system is the risk that the new donor's cells might actually recognize the host as foreign and try to fight or destroy it. This is a condition that used to be a quite frequent and severe complication known as graft versus host disease that typically takes two forms, an acute and a chronic form. Even with a perfect match, even with preventative medicines, this would still develop in patients. Acute graft versus host disease typically occurs rapidly within the first 100 days post-transplantation, and this is an immunologic reaction mediated by donor T cells that are mature and alloreactive and start to fight healthy organs and tissues, most commonly the skin, followed by the GI tract or liver. On the right, you see some severe manifestations of what graft versus host disease or the acute form can look like. In the upper right here, you see an ulcerated hemorrhagic colon mucosa. This is severe life-threatening colon graft versus host disease. And below in the skin, you see widespread erythematous rash, but you also have hemorrhagic bulla. This is a severe case of skin graft versus host disease. And sometimes this can be so severe and extensive, it can behave as a severe burn. Fortunately, recently, these types of severe cases of graft versus host disease are rare, and I'll explain why in the coming slides. Next, we have chronic graft versus host disease, which can occur at any time post-transplant, but historically, we've described it as occurring after 100 days. This is a slower onset of more of a fibrotic inflammatory type manifestation throughout the body. This can be T cell mediated, but also mediated by alloreactive B cells and alloreactive antibodies. This can affect anywhere in the body. Acute GVHD has a typical pattern of skin, gut, and liver, but chronic GVHD can occur anywhere. Most commonly affects the skin, causing fibrosis and sclerosis. As you can see here in this picture, this individual has sclerodermoid change, thickened, tight, hide-bound skin with ulceration. You also see morphea in figure C here, or linear bands of fibrosis under the skin. And in panel B, you see a change called poikiloderma, that is hyper and hypopigmentation, the changes that occur in the setting of chronic graft versus host disease. Patients also commonly can have dry eyes, dry mouth, sometimes lung involvement, pericarditis, serositis, pleural effusions, liver involvement, GI tract involvement, muscle, skin, anywhere can be involved. Kidneys with nephrotic syndrome, almost any organ can be involved. And once this is established, it can be awfully difficult to treat and may not be fully reversible. It used to be that around 30 to 50% of patients, even with a fully matched donor, would develop acute and chronic graft versus host disease after an allotransplant. The way that we've been preventing graft versus host disease since the mid-1980s has been a combination of a calcineurin inhibitor, either cyclosporin or tacrolimus, plus methotrexate, so a 2-drug regimen. But now in 2023, we have a new standard of care called post-transplant cyclophosphamide, and I'd like to show you some of the data as we help to lead some of the studies that are changing practice around the world. So on the top graph, I show results from a phase 2 study that we conducted in well-matched myeloablative transplants. This occurred solely at the University of Minnesota. And in the upper left panel, you see the cumulative incidence of grade 3 to 4 acute GVHD. This is life-threatening acute GVHD, used to occur in 15% of patients with cyclosporin and methotrexate. Now that risk is about 4 to 5% with post-transplant cyclophosphamide. These are historical patients that we're comparing to. And then chronic GVHD requiring immune suppression used to be about 34% of people with cyclosporin and methotrexate as GVHD prophylaxis. But now with post-transplant cyclophosphamide, tacrolimus, and MMF, that is now down to about 4 to 5% as well in the myeloablative well-matched setting. So certainly seeing some marked improvements in the risk of life-threatening graft versus host disease recently with PT-Cy. The graphs below are the results of a randomized phase 3 study done in the reduced intensity setting. So the top is myeloablative, the bottom is reduced intensity allogeneic transplant. And so these were randomized in the study below. And you see that people who are randomized to post-transplant cyclophosphamide had about half of the risk of life-threatening acute GVHD as well as chronic GVHD requiring immunosuppression at 1 year. And so now we're really in a new era of transplantation with much lower risk of life-threatening and severe acute and chronic graft versus host disease. So with the field changing, with graft versus host disease occurring much less frequently with much less severity, what are the unmet needs in our field? How can we continue to evolve hematopoietic cell transplantation? I opened up this question to the Twitterverse a couple of years ago, and with the poll, most people voting said that we wanted to develop GVHD prevention that preserves or potentially even enhances the graft versus leukemia or graft versus tumor effects. But patients commented as well, and from the patient perspective, through the lens of people who have established graft versus host disease and are living with this lifelong, the message was loud and clear. How can we get rid of prednisone? It's been 11 years and I'm still dealing with chronic graft versus host disease. Prednisone absolutely destroys people. The issues significantly impact quality of life. And so we still have more work to do. We need to make the graft versus leukemia effect even better if we can. And then we need to reduce or eliminate the burden of corticosteroids now that graft versus host disease risks are so much lower. To address these needs at the University of Minnesota, we're doing a couple of clinical trials, really specifically speaking to these issues. One study is a study that we hope will preserve or hopefully enhance the graft versus leukemia effect. In myeloablative transplantation, we're testing a combination of post-transplant cyclophosphamide plus sirolimus as our immune suppressant backbone with the addition of an aurora kinase A inhibitor, which is called VIC-1911. The aurora kinase A inhibitor can block alloreactive escape through CD28, basically trying to block any alloreactive T cells, eliminating graft versus host disease, hopefully. But it also has direct anti-tumor activity. And so if we can use this for a brief window of time after transplant, we hope to reduce the risk of relapse with this as well. Now, graft versus host disease will still occur in some patients. It's less severe most of the time. But when it does happen, can we reduce or even eliminate the need for corticosteroids? And to address that concern, we have recently opened a study using pregnancy hormones, which help create an environment of immunologic tolerance, plus ruxolitinib. This is an FDA-approved JAK1/2 inhibitor that is approved for the treatment of steroid refractory acute graft versus host disease, using these two agents in combination with steroids, but testing the lowest possible steroid dose to see if we can greatly reduce or eliminate the need for steroids in patients who have clinically significant acute graft versus host disease of the GI tract. So these are ongoing, and we hope we can continue to evolve our field to make transplants safer, more tolerable, more effective, and hopefully continue to help cure patients so that they don't need to be on medicines long term and can live free of morbidity and free of worry that their cancer may come back. So that is our hope for transplantation. Let's move on now to the next frontier. This is a new area called immune effector cell therapy. Transplants are where we're giving hematopoietic stem cells and we're growing a new immune system from scratch. But what if we can skip that part and just give someone immune cells that can help fight the cancer directly? The most common type of immune effector cell therapy that you'll likely be hearing about and discussing is chimeric antigen receptor T cells, or CAR T cells. We already have a number of CAR T cells that are FDA approved, meaning with the correct indication, patients can already receive these immune effector cell products. How these products work is that a patient goes to the clinic and collects their own T cells through the process called apheresis, similar to the way we collect stem cells, just a little bit different setting on the machine. So these T cells are collected from the peripheral blood and they're shipped to a manufacturing facility where they are engineered to kill cancer cells. There's a virus that's inserted into the genes that will help create a new receptor that can specifically be targeted to the cancer of interest. And then these cells can be expanded in the laboratory, sent back to the clinic where the patient can then receive their own now genetically modified cells, these chimeric antigen receptor T cells that will circulate throughout the body, find and kill remaining cancer cells. Now, this has certainly reduced the number of autologous transplants that are being done for lymphoma. Maybe in the future, it will reduce the number of autologous transplants for myeloma as well. That remains to be seen. We do not know if this is curative in the setting of acute lymphoblastic leukemia, which is one of the indications for this. And so could it be the final therapy, or is it a bridge to an allo transplant in that type of leukemia? I think there's a lot more work to be done to sort that out. But nonetheless, it's pretty remarkable that we can now genetically modify patients' own T cells to help fight their cancer. And it is, again, FDA approved, something that we're doing every day in the clinic. There are other types of immune effector cell therapies that may be FDA approved in the near future. We can isolate different fractions of immune cells that we see in different ways. On the left, we can isolate through apheresis regulatory T cells, these suppressor cells that can help constrain unwanted immune responses. And this has a variety of potential applications, not just in graft versus host disease, but also autoimmune disease as well. We can resect tumors and take the lymphocytes out of tumors, isolate, expand those, and give them back to patients. That's called TIL, or tumor infiltrating lymphocyte therapy, and can be done most commonly in the setting of metastatic melanoma. We can also bank donor T cells and isolate those that recognize and fight specific viruses. So if someone has a profound degree of immune compromise and cannot generate their own endogenous immune response against viruses, we can use these as a bridge until their immune system is more functional to help control life-threatening viral infections. We can also engineer the immune cells, as you just saw, to attack a variety of targets and serve a variety of roles. We can engineer the T cell receptor. You saw the chimeric antigen receptor example. We can also engineer the T cells to recognize antibodies, not just antigens. We can make CAR Tregs that could help, again, constrain unwanted immune responses. We can develop CAR natural killer cells that could go after a variety of targets, including both cancer as well as immune reactive cells in the autoimmune setting or in graft versus host disease as well. So you can already see just from this slide that really the sky is the limit in terms of the number of types of cells that we can engineer for a variety of functions, not just to fight cancer, but potentially have therapy in a variety of immune diseases or other diseases as well. So I just think this is an area that is going to continue to grow rapidly, with more and more patients potentially benefiting from immune effector cells. The University of Minnesota is home to a number of pioneers in this area that have helped to develop regulatory T cells for therapeutic use, natural killer cells, as well as cord blood-based therapeutics. Dr. Blazer, Dr. Miller, and Dr. Wagner are really pioneers, and their work has certainly reached thousands and thousands of patients, and they've helped many around the world develop their own programs to use these therapies and continue to develop them, again, to address a number of conditions well beyond cancer. So we've got some hometown heroes that you should know about. To briefly summarize, autologous or self-hematopoietic cell transplant is a myeloablative transplant, meaning we wipe out the existing immune system and replace it with your own stem cells. that resets the immune system and allows for regrowth of healthy blood and immune cells. This can be done to treat cancer as well as immune diseases. An allogeneic or a donor transplant provides a graft versus tumor effect, but can put people at the risk of graft versus host disease, which is an unwanted reaction. A graft versus host disease prophylaxis regimen involving post-transplant cyclophosphamide has now been established as the standard of care in 2023, and we helped to really develop and refine this regimen here at the University of Minnesota. The originators of this regimen are at Hopkins, but we have contributed substantially to the clinical trials and science surrounding this. And this has markedly increased the safety of transplants and now is being translated at centers all over the world because this is easy and this is inexpensive and very effective in the prevention of severe acute and chronic graft versus host disease. Several immune effector cell therapies are now FDA approved, and more are coming that will provide an anti-cancer effect without graft versus host disease. Some of these are FDA approved, and certainly many more are being developed. And honestly, the sky is the limit, and we'll continue to see market growth in this area. That concludes my brief introduction. Thank you for your time.